Hi, everyone. Good afternoon. Thank you for joining us today for the Ohio AAP Brush with Bed Part 1 Oral Health Training. I wanted to take the time to thank the Ohio Department of Health for their support. This is another webinar of the month that is part of our preventative health program that we have launched recently, and we still have 6 webinars left after this training. Our preventative health program has resources, provider and caregiver resources available for each training, and as well as the caregiver resource being available in Spanish. Our next training is the Healthy Night Routine for Infants on August 4th, and Dr. Duffy will be presenting that training as well, and that is who is presenting the training for today. You can access all of our resources and recorded webinars at the link there. And here is an official list of all the webinars that we have available. We will be having an upcoming breastfeeding panel, 5 screening tools used in pediatric practice, implicit bias, and then connecting families on child health topics through technology. So we're excited to continue on with the rest of these topics. At this time, I will pass it over to Dr. Chris Bowling, who is the medical director for this project. We are getting ready to launch a quality improvement project, and we wanted to share the information with you all. So at this time, Dr. Bowling, take it away.
Great. Thanks very much, Alex. And thanks, Jim, for being here today, too. So as Alex said, I'm Chris Bowling. I'm a pediatrician in Cincinnati, and I'm the medical director for our QI project. We're very excited about this. Alex and I are working on it currently. We got a really good advisory panel of a lot of them are speakers that you're going to see on the webinars here. We're going to be kicking this QI project off in December. It's going to be a 9-month project, tons of resources with you, lots of action calls with content experts that we're going to set up for you. We're very excited about those. And you get to pick the screening tools that you want to use in this QI project. As I said, I'm a general pediatrician in the Cincinnati area, actually in the Kentucky suburbs. And I often, our job is often to do so many different screening tools, and a lot of them become sort of fall by the wayside. We find these things that, work for us for a little while and then they don't work anymore. So what this QI project is really about, and what interested me in it, was trying to find ways that we can make these screening tools more helpful for all of us. And really do that they're really doing what we expect them to do. So I think it's going to be a really fun project. There's a lot of latitude for you to go in directions that are of interest to you and of importance to your particular patients. So you can really kind of follow your bliss on which ones you pick. So we hope you'll move along with us, and we would love for you to join the QI project with it as we move forward. There are a lot of good things along the way, a lot of good extra little benefits that you'll find as we move through the project. So with that, if you have any questions, be sure to just reach out to Alex or anybody here at Ohio AAP, and we can give you more data.
Great. Thank you, Dr. Bowling.
Pleasure.
Now I will go ahead and pass it over to Dr. Duffy, and we will get started with the training today. If there's any questions throughout the training, please feel free to put those questions in the chat box, and a CME survey will be sent out to you all on Monday. And please let me know if there's any questions in the chat box. I will go ahead and pass it over. Dr. Duffy.
Well, thank you. Thank you, Alex. And I thank you all for joining us this noon. I want to first recognize a couple of things. One is Alex done a great job putting this together, and she's very, very helpful and thoughtful and really has much to offer to the American Academy of Pediatrics, the Ohio chapter. So thank you, Alex, for putting this together. Also, always when I do these, I want to recognize that I'm at home, as many of you are. I live on Shawnee traditional homeland, and I want to recognize the caretakers of my land and commit to them that I will care for our land for the future generations. You see my CME disclaimer. Alex, I'll just say next slide. Thank you. This presentation is, the core of it comes from Brush, Book, and Bed, which is a program that the American Academy of Pediatrics put into place a few years ago. It's a QI program. We did a year of it here, but our Healthy Tomorrows grant was not funded, so it was laid down. I still have the PowerPoint, so I've adapted the PowerPoint to the current situation. And actually, I want to recognize the oral health division, the experts at the Ohio Department of Health who reviewed my slides and really added much content that's really important. That said, we have about, let's say, almost about an hour, 55 minutes, 57 minutes. And Alex and I were talking a minute ago about the fact that the slides are full of data, full of information. That's not generally how slides should be, but we'd like you to have the opportunity to go back and look at the slides and copy them down and use the information. So the slides are dense. I won't read them to you, but be aware that there's a lot of information on each slide. Next slide, please. The learning objectives of this particular part of oral health are these. As we start the presentation, I always start to remind folks that one of the most important aspects of primary care pediatrics, particularly in the first 3 years, is to promote relational health. As you recall, and I'll say in a minute, that the most important mitigating factor to early childhood adversity is a strong, safe, secure, nurturing relationship with an important adult. And that can happen anytime. That teachable moment can happen at any time during the first 3 years, during well child visits or even sick child visits. And in particular, the oral health program is important, as I'll talk in a minute, that it needs to be 2-generational. We are concerned about the mother's health primarily prenatally, but also the caretaker's health of any caretaker that's caring for the child in the first year or two. And I'll go through that. So we talk about routines, how to do an oral health assessment, and I'll provide some extended information about implementing fluoride varnish procedures within a primary care practice. And that can be either a pediatric practice or a family practice. Next slide, please. First, a couple of comments about relational health. Next slide. As I mentioned, this comes from Jack Sean Kaufman, his program at Harvard. The most important and frequent commonality in children to succeed is that they have at least one stable and committed relationship. So it seems to me that there are a few evidence-based interventions or evidence-based activities in primary care, and we'll talk about one of the more important ones next time. This is part 1 of 2 parts, and the part 2 is about books and bed, and so I'll talk about reach out and read. But relational health covers all of these. The relational health the promotion of relational health, looking at, for instance, serve and return, or mimicking the kinds of things that are having the thought of the child in mind. These are activities that pediatricians and pediatric clinicians can do at any point during a well child visit, and oral health education and the oral health exam is certainly one of them. Next slides, please. This is a little bit redundant, but I want to emphasize that these are some things that anybody can do. Engage, serve, and return. Recognizing temperament variations. We talk about how children, the invasion of a child's mouth is an important activity for children. Many children resist. So matching the temperament of the caretaker with the temperament of the child, and understanding the difference in temperament responses to new situations and new people really is an important to understand the relationship between caretakers and children and promoting relational health, encouraging self-reflection. And that's another sort of 2-gen approach to understand, even within a pediatric clinic, how it was done during the parent's own or the caretaker's own childhood, and how it might be different now, and encouraging self-reflection about these activities. And I'm including all three of the primary topics, which are oral health, early childhood literacy promotion, and bedtime routines. Next slide, please. Once again, 2-generational. The Frameworks Institute put this together, and I like this phrase: 2-gen approaches build family well-being by intentionally and simultaneously working with children and adults. This is something that is really very important when you're talking about intergenerational trauma, but also poverty, many different circumstances. And again, it has particular salience within oral health promotion. Next slide. So here we are. Next slide, please. A little bit about understanding oral health. What is the normal flora and where does it come from? Well, the normal flora is colonized at least or before the time of tooth eruption. And it's important to realize that caries in particular is an infection initiated by cariogenic bacteria, strep mutans. Now, primarily, there may be others, but that's the primary one. And the important part of that, I think, is that well, there's many parts that are important. One is that strep mutans can be transmitted vertically from caretaker to child, and that may be one of the main reasons for early childhood caries, and caries as a family pattern. We'll come back to the presence of fluoride, but growth of bacteria is determined by the frequency of exposure, available substrate, oral hygiene, and the presence of fluoride. Next slide. Just once again, it's just a general statement of what it means to children. The prevalence of caries in children and youth. We talk about early childhood caries 0 to 3 or maybe 0 to 5, but at least 1 out of 5 children have early childhood caries. About half the children in the school age years, and another half between their teens. And if you want to sort of trick people and say, what's the most common chronic infection of childhood? They may say ear infections, they may throat infections, but they're wrong. It's really tooth infections or gum infections. The prevalence of caries is the most common infection of early childhood. 5 times more common than asthma, 7 times more common than allergic rhinitis. Next slide, please.
You gotta put the thing on.
So this is a graphic that shows the sort of the pathophysiology of caries, the tooth itself, and the morphology of the tooth, trace elements, nutrition, the substrate, oral hygiene, the saliva, the acidity of the saliva, the frequency of exposure to carbohydrates, and the presence of flora, particularly strep mutans. Next slide. The substrate is particularly important. Caries is promoted by carbohydrates, which break down to acid, and the acid takes care of the enamel, and the enamel demineralization allows for invasion of strep mutans. Frequent snacks or sugary drinks produce or promote these attacks, but there are other hidden sources, as you can see on the slide: breads and cereals and pastas. These are all carbohydrates that are turned into sugars and turned into acid, and breaks down the enamel, which allows invasion of the cariogenic bacteria. Next slide, please. And here's where it is. This is the important part of the 2-generational approach. Infection occurs primarily from mother or primary caretaker to infant within the first 2 years of life. So it makes sense to go upstream. It makes sense to go upstream to encourage oral hygiene in the parents, and particularly the mothers, but also the other caregivers. The mother's oral hygiene is extremely important because that's usually the first exposure. But as we know, children or babies are cared for many people, many family members usually, and so the oral hygiene of the family is important. Next slide. And as a matter of fact, the American Academy of Pediatrics, along with the CDC and some of the dental organizations, put together an initial project a couple of years ago called Protecting Tiny Teeth. And the Protecting Tiny Teeth was a project of increasing awareness of oral health of mothers, of pregnant persons, and also allowed for, well, in terms of their evaluation of the project, they also included referral to specialists, to dentists, if not available. And the particular questions, these are questions that come from essentially from ACOG, the American College of Obstetric and Gynecology. These are things that we could ask parents in second time around if we have parents who become pregnant, whether in their or in our practices as pediatricians, but certainly family practice doctors and people. Again, and FQHCs are really important in this regard because FQHCs have integrated medical and dental care for the most part. And so if they don't have a dentist on site in FQHCs, they have a memorandum of understanding so that they can refer directly to dentists within the community that will accept the sliding scale of the FQHC. So these are questions that we could ask mothers who are pregnant. Do you have swollen or bleeding gums, a toothache? When was your last dental visit? And importantly, do you need help finding a dentist? And extremely important. There's a toolkit and a summary of the evaluation outcomes at the website that you have listed there. I recommend you look at it. Their run charts are really quite impressive in terms of improving oral health education as well as referrals and successful referrals to dentists. Next slide, please. So what happens when kids have early childhood caries? Well, these are the main ones. We see them all the time. We see kids that can't sleep. They can't learn in school and early childhood education. They have poor nutrition, poor growth trajectory in the worst cases, and of course that it predicts for adult dental decay. Pain is a problem, and a spread of infection. Occasionally, we don't see that often, but we do see sometimes. We see, the periorbital cellulitis or suborbital cellulitis, which an extension of the infection into the maxillary sinuses. And, it's terrible for kids. Next slide. At the Ohio Department of Health, we work particularly. I've been on the Medical Advisory Council for BCMH for a lot of years, and one of the difficulties we have is finding dentists that will take care of kids with special health care needs. These are kids that generally have. Many children have suboptimal exposure to topical or systemic fluoride. They're difficult to care for in some ways. Poor dietary and feeding habits, and kids that are difficult to manage their own oral hygiene. Next slide, we'll show you that. So this is, for instance, in the old days when, well, it's not not in the old days, but many times people, doctors who are care for children with special health care needs, particularly children with medical complexity, are sensitive that the oral medicines that are used are sugar free, and that's really important. This slide is purported to be a damage caused by holding medications in the mouth, and I certainly have seen that. The last part of my clinical career was at Dayton Children's as the director of the program for children with medical complexity, and we saw kids like this, and we had in-house dentists, but even when there were in-house dentists, it was difficult to find appropriate care for children with bruxism, or children with serious problems that would require anesthesia for correction. But these are some of the things that we'd like to emphasize: preventative measures, refer early, and in particular, watch the impact of oral medications and choose non-sugar containing medications. Next slide, sorry. But in a primary care situation, and leaving the special healthcare needs kids aside for a minute, these are sort of the roles of what we do in primary care. We assess oral health. Now, there are formal risk assessment tools. I never used them when I was in practice. Maybe some of you could put into the chat your experience in terms of using risk assessment surveys or instruments if you use those. I did not, so I don't have direct experience. I've seen them. I didn't find them that particular instrument useful, or even more useful than direct examination and questioning or surveillance. But secondarily, again, the 2-gen approach is to evaluate the caretaker's oral hygiene. We recognize early signs and symptoms, and we discuss and determine the child's exposure to fluoride, and we apply fluoride varnish in Ohio, which is really an amazing improvement over the past 15 or 20 years to be able to apply fluoride varnish within a pediatric or a family practice setting, rather than requiring dentists. Before, I think 2005 or so, the fluoride varnish had to be a dental procedure, and since that time, the fluoride varnish has become a primary care. And I know all the academic programs apply fluoride varnish, and many FQHCs do. It's something that we'd like to see all practices do for children. Next slide, please. So a little bit drilling down on the oral health assessment. Lift the lip to inspect and assess for the presence of plaque, presence of white spots. I'll show you some pictures in a minute. Presence of crowding. And we provide education on brushing with fluoride toothpaste. And some of the particulars, including, I think there was just a comment in the chat about reimbursement, and we'll get to that in a minute. Private insurances still are slow to reimburse, but Medicaid reimburses. So next slide. You were right. So here's a bunch of variations of normal teeth. Some of these look a little close. There's a little bit of a crossbite, particularly in the lower right, but these are things that probably can correct themselves and not a serious crossbite. It's hard to tell about that one on the lower left, but these are some things. These are the teeth themselves do not show signs of caries, and that's sort of the next part that I'd like to show, and so we can move on to the next slide. So here's the white spots. This is the earliest sign of a problem. You see the white spots right along the gum line, right along the gingiva. These are areas, and there's brown spots on the one on the upper right. That's a little bit further along, but you see white spots even before brown spots. And these are signs of a deterioration of the enamel that's visible to after you lift the lip to look at the teeth. And as a matter of fact, I'll anticipate what I'm going to say in a minute, and that is that fluoride varnish can reverse white spots. Has a little bit more difficulty with brown spots, but certainly white spots can be the earliest stage of caries formation can be reversed with fluoride varnish application. Next slide. And this is, further along. These are brown spots. This is destruction of the enamel, and they're showing the front teeth, and really the next stage of this is what we talk about as bottle caries. The kids that go to sleep with a bottle and have the milk drip on there, or sugary drink drip on the front teeth, and those front teeth rot away. And certainly that was something I saw very frequently within the clinic before we initiated fluoride varnish and before we initiated the oral health programs. I hope that the frequency decreased after that. Next slide. So here's sort of the anticipatory guidance on instruction on brushing. Children younger than 3 years should use a smear of toothpaste about the size of a grain of rice. Children 3 to 6 should use a small dab of toothpaste about the size of a pea. So you graduate from rice to a pea. Younger than 3 is a rice, older than 3 to 6 is a pea. And once again, I've emphasized the 2 generational aspect of oral hygiene by showing how we can model good oral hygiene for our children, and having the parents brush at the same time, even if they brush again later, even if they stay up later, but brushing while the children brush, I think it's important. Next slide. Flossing may be a little bit more difficult, but the little applicators, the little plastic implements that you see used in this grandparent, I think, is using that, starting whenever 2 teeth touch. Once a day. Now, brushing can occur more than once a day. That's certainly the least. It would be twice a day, but also can be after every meal, or if once kids get acclimated to 3 meals a day. Next slide. So let's talk a little bit about fluoride. Fluoride is a naturally occurring mineral that strengthens an animal. That, as you say, that if you have carbohydrates and the acid forming from carbohydrates breaking down an animal, fluoride then works the other way, protects against caries by strengthening the enamel. Community water should have about 0.7 milligrams per liter. And that's when water is fluoridated, and in communities in which their water is fluoridated, should have about 0.7 milligrams per liter. And that in large studies, multi-state, multi-location studies have shown reducing caries by about 25%. Some people worry about fluorosis. Fluorosis is when the child has a little bit too much fluoride, at least, and that's a sort of a systemic exposure to fluoride, drinking fluoride, or let's say eating toothpaste, or having too much fluoride in the water, in the groundwater. It's only cosmetic. It causes small white marks that are different in appearance than the white lesions of early caries. It's really often at the tip of the tooth, and you don't really see it. The dentist will see it, and sometimes parents will see it. Doctors or clinicians may see it, but it's rare. It's cosmetic. It's important to realize it's clinically insignificant. It occurs in places where the groundwater has a high concentration of fluoride. The delivery mechanisms of fluoride are these. I mentioned it's the groundwater, the community fluoridation, oral supplements. Those are systemic exposures. The topical exposures are toothpaste and gels, and in the office, foam in the dentist's office, and varnish either in the dentist's office or in the primary care office. I've also heard of people using foam, dental hygienists using foam within Head Start classrooms, so that you may run into that. Next slide. These are the sort of the guidelines of supplementation. I'm not going to go through this a whole lot. One of the important things that there is a search engine for community water system fluoridation. Those of you in Kentucky or Indiana have benefit from that, but Ohio doesn't participate, doesn't provide our information. So it's not that easy for us. We really have to contact our local water utility agencies and keep a list. We did that in Springfield. I practiced in Springfield for 25 years, and Springfield is the largest metropolitan area in Ohio that doesn't have fluoridation in the water. That's where I had to learn much of what this talk presents, because we struggle with it, and we had to call the local, the community agencies, the water system agencies, and find out, or even look at the local water maps, which is on the next slide, please. Next slide, Alex. There it is. This is really just impressionistic. It's impressionistic regarding the amount of groundwater fluoride in the groundwater. It's interesting to me because that red line, as most people know, is the extent of the Wisconsin glacier. 10 to 20,000 years ago, the glacier came down, left the Appalachians, and scraped flat the northwestern part of Ohio. And apparently, there's more fluoride in those areas rather than within the southeastern area of the state. It's an interesting map, but honestly, those people who are in the regions, particularly in the northwest, will have to be careful a little bit about contacting their local health department or local water agency to find out how much exposure children have in those areas. Next slide. There we go. So this is a picture of a little girl in my practice years ago who was the poster child for the Smiles for Ohio pamphlets, and this was this is about fluoride varnish in primary care, and she was one of the first that received the fluoride varnish. Fluoride varnish doesn't require any special equipment. It's not associated with fluorosis. Fluorosis only comes from systemic exposure, and it's safe and effective and generally well tolerated. I think it's a very easy kind of activity to engage in. Next slide, please. It reduces caries by arresting demineralization, same things we've been talking about, adding fluoride directly to the surface in a sticky material that has a number of different tastes, but usually tastes sort of like bubble gum. And the 25 to 45% reduction in early childhood caries is extremely important if you start at 6 months or starting at tooth eruption through 3 years anyway, at least twice a year. We added another one for kids that seem to be particularly high risk, and it reverses white lesions. those 45% reduction in early childhood carriers probably is conservative. It may be higher than that. I saw the Fluoride Varnish was initiated in Florida and North Carolina in the 90s, and in some older kids in Head Start classrooms, the reduction was actually higher. It took a bit. It took a bit for the American Academy of Pediatrics to really do the work to get Fluoride Varnish in the 0 to 3 or 0 to 5 age group, since traditionally those groups weren't seen regularly by dentists. They were seen by us, and that was the argument we used with the state to allow or permit us to apply Fluoride Varnish within a pediatric setting. Next slide. And this is sort of a couple of different techniques. The Fluoride Varnish comes in a little packet. It's a single-use packet with a little brush and the varnish underneath. There's the slide on your left is a little bit old. This, if you really want to use a finger caught to make sure that the kids don't bite you, or if you want to use 2x2s, that's perfectly fine. Most people don't use those things and get by without them. We never did, but I understand that some do. So I included that as an option. Next slide. And this is a picture of sort of a happy child, and the way we did it in our clinic with the nurse practitioner applying Fluoride Varnish, and I'll talk about a clinical flow in a minute. But you see that she was not using the as a pre-COVID, obviously there was no face mask, but she was using gloves and not a finger caught or the 2x2. Next slide. Different techniques. Some people use the lift the lip and apply the cotton gauze. I don't think that's necessary. In fact, the original direction was early on. We asked for people to not eat for a couple hours. And it's probably a good idea, but it may not be necessary. And if it's a hardship, you just go ahead and apply the Fluoride Varnish. Next slide. And here's the payment information. I'm not certain how much is paid by Medicaid at this point. For a while, it was as low as $7 or $8. It may be as high as 15. But as you see, this is current information from the administrative code. It can be applied by a physician assistant. In this case, that could be an MA or an advanced practice nurse, a nurse practitioner. And it could be part of the, and it's unbundled. It's not part of the EPSDT visit, and the payment for the application of Fluoride Varnish is made separately. It's unbundled from the well child visit or a sick child visit. And the CPT code uses 99188. And as in the, other people may be interested to post in the chat about their experience with local private insurances. All the Medicaid managed care organizations support this particular regulation and payment. Next slide, please. I might say this: it's so inexpensive and so effective that billing the insurance company over and over again, going ahead and doing it and billing the insurance company as you would bill, as long as it's not, as long as it's not bounced back to to the family, or maybe something you want to provide the family information that your insurance company may not reimburse for this. You may find it on your bill, but as long as your cost is low and you're passing along the cost that's low, that seems to be something that still could have some benefit. Back in the day before modifier 25 was reimbursed, we routinely filled out. We charged for modifier 25 and filled out the extra paperwork until the managed care organization started paying for it, and now they don't pay for it. So here's a list of anticipatory guidance. You know pretty much all of this, so I'm not going to read it. One of the things that that I want to point out is what we see often in the clinic is caretakers cleaning off the pacifier and putting it back into the mouth. And as we just talked about, that's how children get colonized with strep mutans. So that's really important. Just as an aside, an anecdote is that I saw a 9-month-old one time with basically a raging exudative tonsillitis, tonsilopharyngitis, and it turned out to be strep. But I asked the parent, the mother in this case, whether she chews her food for the child, and she first denied it, and then she embarrassingly said yes, she chews the meat because she thinks her child at 9 months should have meat, so she chewed the meat, and then took it out of her mouth and put it into the child's mouth and gave the child strep. So, this is the time that you really have to think about 2 generations and be sensitive and not being harsh or punitive or blaming, but just for taking care of the child, taking care of the parent. Next slide, please. And here's a little bit more. A pea size amount of fluoride varnish from 3 to 6. I start flossing the teeth and help supervise the child. And I think that the best way to do it is for the parent to or the caretaker to brush along with the child until the child is able to do it on her own. Next slide. And here's the clinical flow. You do sort of the pre-visit, and provides the handouts. During the Fluoride application, usually is last before the immunizations, but usually last. And at least in our practice, there was a seamless transition from oral health assessment to fluoride varnish applications. You see in your upper left, the nurse practitioner actually sits knee to knee with the caretaker, and the infant then is embraced face to face by the caretaker, and then leaned back on the nurse practitioner's lap. And that allows for the nurse practitioner to lift the lip and do the oral health assessment and apply the fluoride varnish. And the child, when he or she opens her mouth or her eyes, she sees the caretaker instead of the scary person who's putting something odd in the mouth. Then the post-visit, the clinician documents the fluoride varnish and submits the code, and nurse documents the oral health assessment. I hope most of you are using after-visit summaries, at least in some form, either in a paper form or in a electronic form. And that's where the oral health education and then the referral needs to occur. Next slide. Now, I skipped this part on the earlier slide for anticipatory guidance for infants, but I want to make sure that we emphasize this. Refer children, high-risk children, by 6 months, and all children by 1 year. In the ideal circumstance, we refer children to a dental home before 1 year. In reality, that's very difficult because of workforce problems. It's not quite as bad as looking for a psychotherapist, but it still is very, very difficult to find, particularly find pediatric dentists that accept Medicaid, for instance. At least in our area, it has been. Once again, you might document your experience within the chat. Next slide, please. And here's the summary, and we'll have a little time. It looks like we'll have a little time for discussion. We apply the 2-gen approach. We talked about the need for taking care of the oral health of the mother, the pregnant person, as well as the important caretakers in the first 3 years, because that's really when the oral biome is established, and particularly the transmission of strep mutans. At any point, we use, some of you are experienced enough to remember Barry Brazelton and his teachable moments. We'll talk a little bit more about Brazelton's approach to sleep time problems in 2 weeks. But I would say that this is a teachable moment. These kinds of circumstances are teachable moments that we can improve attachment and promote resilience, and in general promote relational health within the pediatric visit. We provide guidance and monitoring. When I'm speaking here is parental self-efficacy rather than the child self-efficacy. Help establish good habits and complete the oral assessment, including signs of early childhood caries. Assess fluoride exposure, apply fluoride varnish, and early referral to the dental home. So that's the summary slide. I think my next slide then gives additional resources, and we can go back to some of the questions in the chat, and you might we have a few minutes to talk. But the fluoride varnish application, the medical office, this is an article that's linked here from the Ohio Association of Family Practitioners. Ted Winslow is the primary author of that, and I think many of you remember Ted Winslow as the medical director of the Ohio Department of Health, and then later, more recently, he's been the medical consultant to the Ohio Association of Community Health Centers. And my understanding, and I think I'm right about this, I think he retired just a couple of weeks ago. So congratulations to him. He was very influential, particularly in promoting the medical home for adults in 10 to 15 years ago when he was at ODH. Smiles for Life Oral Health is a really good resource. There's self-paced learning opportunities on that website that's linked. And there's a little bit down at the bottom left there underneath the Smiles for Ohio picture is a web, actually an application for phones. So you can use it yourself, or you can ask parents to download that. It's very for Smiles for Life Oral Health. It's a very useful website. That's all I have today. Now, again, in 2 weeks, there will be another seminar, and we'll do the second half of this talk. The first half, again, was oral health. The second half of the brush book and bed. The second half is the is the early childhood literacy the use of books during a bedtime routine, and talking some about bedtime problems. In particular, I'm going to spend a little time on anxiety, since we have a major problem with anxiety in our practices right now, and so this is a bedtime routine is one of the times that anxiety is really strongly expressed. So we'll spend a little time talking about that. So Alex, do you want to take it from here? I haven't seen these. These are resources from ODH.
We created these, and these are new. So here's some resources that we'll have available. But this was all taken from Dr. Duffy's presentation and put into format for flyers, and then the caregiver flyer will be available in Spanish as well. And then at this time, we'll open it up for questions. Dr. Duffy, there's a few questions in the chat box. Do you want me to read them to you?
No, I'm going back. Let's see. Can somebody comment on insurance coverage for topical fluoride in the PCPs? I certainly have. I don't know what institution, Sean, where you are, so I can't particularly comment on that, but certainly this is an opportunity for advocacy. It could be opportunity for advocacy through our pediatric council, through the Ohio AAP, who may be helpful in getting encouraging the managed care organizations to support fluoride varnish. I know all the Medicaid does. Some private insurances have in the past. It may just be something that is a continued opportunity for advocacy within your institution and with the larger system. Do you have any, Sean? Do you have any? Yeah, it's something I continue to agitate for. I agree, and I don't have any easy answers there, but it's certainly something that really should. One of the problems here is that a lot of the insurance companies don't have a long view; they have a short view, and they don't do things because they know that those kids likely aren't going to be on their insurance later on. so these activities that don't come to fruition for 20 years are not within their sense of. Yeah, you got it. You're right. The cost of varnish is like $2, so no reason we can't just eat the cost. I completely agree, and that's one of the ways of that's really one of the ways of advocating. You just continue to turn in the charges. I use the example of modifier 25. There was a time that we could not do a sick visit and a well visit the same day, but most of the kids come in sick, and so what do you do? And now it's possible because we continue to fill out to advocate for that and to complete the additional paperwork and turn in the charge. And Alex, it might be something to pass along to the pediatric council to bring up in one of their meetings.
Of course. And then there was another question about evaluating a parent might feel a little intrusive, but do you suggest history questions like, are you prone to cavities, or do you see the dentist regularly 1 to 2 times a year?
Yeah, these are some things that are built on trust, and in my practice, I think people would be pretty easy about sharing their own problem, particularly if you're saying that, we're interested in family wellness. You move away from the. I like that slide on the frameworks. If you're not familiar with that particular group, I think that's a worthwhile for when you can kind of get away from doom scrolling and look at the framework's website, because they have really done some really good research and make very good suggestions. Really need to stay away from blaming. There's no blame. You have to figure out a way to say, that caries is or tooth decay or hygiene, good hygiene, is a matter of family activity. And we want to promote the family wellness and the family security, rather than trying to blame parents for transmitting these bad bacteria. So it's something to finesse, but I think it can be done if you have a trusting parent, and you want to go only as far as the parent is comfortable. So if the parent is comfortable just talking and answering questions, or if they're just comfortable receiving the information, or perhaps sometimes they would be comfortable talking about it and responding if you ask, do you need some help finding a dentist? We have a list. We have somebody here who keeps a list of local dentists who are accepting patients and even accepting patients. You can find, so this is a practice-based care coordination activity to keep a resource list of dentists who are accepting new patients and accepting certain. And somebody, frequently in an office, there's a receptionist or a nurse or even somebody in the back office who knows the community very, very well, knows people in the community, and can negotiate that and make some telephone calls and keep a resource log. Something that could be done within that practice. Okay, what else?
Just some comments about having problems with people being able to find dentists that accept Medicaid, which you touched on a little bit. Are there any other questions?
I can't quite understand I think it's unfortunate that baby bottle caries is named such as grazing nursing infants I've seen with the same caries, and parents have been indignant that it couldn't occur this way. Right. It's less common with breastfeeding, and we certainly think that in general, parents should breastfeed as long as they can, through at least up to 12 months if they can. So I understand the problem, but I also say that it's probably important to concentrate on the carrying around a bottle with something in it that has sugar. I often said that, for instance, when parents would say that I really need to put my baby down with a bottle at night, I think it's very reasonable, at least at certain ages, to put the baby down with a bottle at night, but just don't put something in that has sugar in it. I often recommended peppermint tea, for instance, slightly warm with no sugar in it, or even chamomile if there's no problem with that's typically the sleepy time tea, the chamomile or peppermint. Peppermint is yerba buena, which is the good herb. I trained in Texas, and most grandmothers had a little plant of peppermint by the back door that they used for their babies. So as long as it's not something that has sugar in it, I think that a bottle is okay up until a certain point. Of course, you can get into the later stages where the bottle is pushing the front teeth forward. That might be a problem, but certainly up to into the second year. So there you have it. Looks to me like that's about the last that we have, and it's 3 minutes to 1. Any final thoughts? We'll meet again in 2 weeks, and you're welcome to join for the second part. I'll talk about relational health promotion to some extent, but concentrate on early childhood literacy or the use of books to help with bedtime routines, and then talk a little bit about bedtime routines and anxiety going to bed. And thank you for tuning in today.
Great. Thank you so much, Dr. Duffy. And Dr. Duffy will also be one of the advisors on our quality improvement project. So if you're interested in this topic, he'll be advising on a few other topics as well. Please reach out to me about the quality improvement project, and we'd love to have you participate. Thank you everyone for joining. Thank you again to Dr. Duffy. And we will see you again in 2 weeks on the next part of our training. I will send out the survey as well as links to the recording and slides and resources on Monday. Thank you all so much and have a great rest of your day.